I just want to get a quick show of hands. Are there any physiatrists in the audience? Okay, I didn't think so. Does anybody know what a physiatrist is? Raise your hand. Yes, I got my Milwaukee friends at least. All right, that's good. Okay, so I'm a physiatrist. So if you didn't know one before, now you do. A physiatrist is a physician who specializes in physical medicine and rehabilitation. And we are a small specialty. And part of my specialty is explaining what I am, because a lot of people have no idea what I do. And that's okay. I'm here, I'm an advocate for what we can do for cancer patients. You're probably more familiar with physiatrists taking care of more catastrophic disability like traumatic brain injury, stroke, amputation, polytrauma. We run our polytrauma across the VA systems. But there is a small group of us who are subspecializing in rehabilitation for cancer patients, and I think that there is a lot of good work that we can add to what you all are doing in treating these patients' cancers and aiding in their recovery and rehabilitation into their survivorship phase. So I'm going to talk today specifically about rehabilitation for head and neck cancer, but just kind of keep in mind that what we do really applies to most different cancer types. And if you haven't thought about referring your patient to rehabilitation for any physical functional problems, you might think about it after today's talk. All right? So these are just some disclosures. I do have a little bit of grant and research funding, hopefully more in the future. And these are going to be our objectives today. So first we're just going to talk just broad strokes across cancer patients. What are these functional needs and are they being met? And there's been a broad, rich base of literature to kind of support these findings, not so much in the head and neck cancer, but I'm hoping to change that in the future. Then we're going to turn our attention to head and neck cancer specifically and go over some of the common functional and rehabilitation issues. Dr. Murphy did a great job of talking about the nutritional, dietary aspects, and I'm going to focus a little more on the physical function problems. And then, if we have time, briefly looking at some opportunities for research and some future directions. So the first question is there a need for cancer rehabilitation? And obviously it's rhetorical. Why would I come here if there wasn't a need? But as you can see, there's been quite a few studies that show anywhere from 50 to up to 90% of patients report functional impairments. And when you talk to a rehabilitation provider about what is an impairment, this is the International Classification of Functioning Disability and Health, which is like the bread and butter for a rehabilitation doctor. But impairments are really things, problems with body function and structure that affect your ability to do daily activities like mobility, self-cares, things like deconditioning. Interestingly, there was actually a study done at a VA oncology unit that showed almost 90% of veterans within an inpatient VA oncology unit reported some functional impairments. And the most common of those was basic mobility and ability to do self-cares. This is a study from Dr. Lehman, who was one of the first physiatrists who thought that we could actually help with cancer patients. And he just did a very simple survey a long time ago already and looked at what are the needs of cancer patients, what are they reporting, and most commonly psychological needs. So we just had Dr. Moy's talking about some of those. And then after that, more physical needs like generalized weakness, difficulty doing your activities of daily living, pain, difficulty getting around and ambulating. And then another look at, well, what percentage of people within the different tumor types reported these functional impairments. And as you can see, the more common types, no surprise, are tumors of the nervous system. So you can imagine someone with a brain tumor or a metastatic spinal cord lesion would be a very appropriate rehabilitation patient. Breast cancer patients, there's a talk tomorrow from a physical therapist talking about breast cancer rehabilitation, and that's probably the most literature for rehabilitation has been with breast cancer patients. But I thought this was interesting. Head and neck cancer is up there. It's really a lot of quality of life and functional things happen from here to here, all right? So it's not just communication, swallowing, it's neck and shoulder range of motion, pain, ability to use your arm to brush your teeth and wash your hair. There's a lot of things that happen as a result of head and neck cancer. So after we've kind of seen that there are a lot of rehabilitation needs, sadly, very few cancer patients actually receive rehabilitation services. There was one study actually done at the Milwaukee VA looking at, this was done several years ago, looking at our palliative care unit, and at that time only about 40% of veterans actually received physical therapy. This has improved dramatically since then, I can tell you. And in a larger study, about 40% of outpatients with cancer reported these unmet needs. So they had problems with physical function and mobility, self-cares, but those needs were not being met. And in another study looking at an outpatient VA hem-onc practice, there was a median of 3 unmet rehabilitation needs. And again, the most common ones were physical function and ADLs. So really, what are the barriers to getting our patients to cancer rehabilitation services? One of the themes that kind of comes up when you review this literature is, we're a referral-based service. So if those problems aren't being recognized and the referral isn't being made, then they're not going to be able to benefit from the services. And I don't think this is any finger pointing or anything. I do think that there is a different, maybe a shift in frame of how you think about these types of things. Neurologists, orthopedic surgeons, neurosurgeons, these are people that we work with very, very closely traditionally in rehabilitation. And I think now we kind of can do a better job of educating oncology providers of all the things that we can also do for your patients. And then I think the bigger issue is just kind of identifying these functional problems. Not everybody thinks like a physiatrist. If you don't even know what one is, it's okay, because you're not going to be able to identify those functional needs. And one study that I think demonstrates this pretty clearly is done by Andrea Cheville out of Mayo Clinic. She just did a very simple study where she administered a list of cancer-related symptoms, signs, and functional problems to cancer patients, mixed population, in a waiting room in an outpatient oncology practice. And then she compared what the patients reported to what was actually being documented in the medical record. Because as you know in medicine, if you didn't document it, it didn't happen. So interestingly, 65% of patients reported at least one cancer-related functional problem, and I have a couple more slides to show you what they were reporting. But only about 6% of providers actually documented these functional problems in the chart. So really there's this disconnect between what the patients are experiencing and maybe what they're telling their providers, and kind of moving from there. So this is the patient-reported needs. And as you can see, about 70% reported any symptom, and here are the symptoms along the bottom. It's a little blurry, but things like fatigue and pain. About 30% reported any signs, so things like weight loss, swelling. But 65% of patients reported a functional problem. And if you look towards kind of the right side of this graph, again, it's coming back to really simple things: insufficient strength to perform activities of daily living, needing help with ADLs, difficulty lifting, problems with walking. So like I tell my residents all the time, rehabilitation is not rocket science. It's very, very basic daily needs. But if you don't ask the patients, if you don't assess what they're actually needing help with, you're never going to know what their needs are. And then this is looking at what the providers actually documented in the chart. And so, about 50% reported that the patient was having symptoms, and about 40% reported the patient was maybe having signs related to their cancer. And this, demonstrates what you guys are so wonderful at doing, is recognizing that, yes, the treatments and the tumors and things have side effects and have issues, and we can treat them. We have a great literature within palliative care that says there's all these things that we can do to help cancer-related symptoms. But what was not recognized was the functional problems. All right. So this is absolutely an opportunity for rehabilitation providers. So this is just break it down really simple. When should I refer my head and neck cancer patients to PM&R, or really any rehabilitation provider? So if your patient has neck, shoulder stiffness or pain that isn't getting better, you've tried a couple simple things, you're not sure what's going on. If they have swelling, so we heard about lymphedema a little bit, but if they have swelling after treatment, if they have any kind of neurologic symptoms, so numbness, tingling, weakness, muscle spasms that you can't really get a handle on, And then there's very basic functional things, difficulty doing normal daily activities. Ask them, do you have problems combing your hair? Do you have problems getting dressed? Do you have problems reaching up into a cupboard to get a glass? And then, of course, cancer-related fatigue. Now, all these things kind of seem a little bit broad, but we'll go over in a little bit more detail kind of what rehabilitation can do for these patients. So, again, these are just some very specific issues to the head and neck cancer patient population. So shoulder dysfunction is thought mostly to be due to spinal accessory nerve issues, and not only in the radical neck dissections where the nerve is actually removed, but actually there's a lot of kind of pretty good data to show that even when the nerve is spared, it's still dysfunctional, meaning that even though the nerve is not cut, it might be stretched. You might still have problems with the muscles that it innervates, most specifically the trapezius muscle. Even if the nerve is not being affected, if you're having pain from recovery from your surgery, if you're kind of getting through your radiation treatment, you're not using your shoulder as much, you're still at risk for developing things like a frozen shoulder or rotator cuff pathology. Now, this is interesting because in 1-year survivors after head and neck cancer treatment, the range of motion is actually still reduced, and usually it's with flexion and abduction. And this is for all types of surgeries, all different stages, kind of across the board. And then in an unpublished paper that we're still working on right now, in 5-year survivors, you can actually correlate the decreased range of motion to their overall quality of life, and more specifically to their shoulder impairment and disability ratings. Now, lymphedema, as we heard a little bit about, so it's accumulation of protein-rich fluid, so it's not just fluid. And this leads to this chronic inflammatory response and fibrosis underneath the skin. So it's not just water. It can lead to very much thickening of the skin, decreased range of motion, pain, difficulty swallowing. The risk factors, a lot of it has to do with what was their tumor like, what type of surgery did they have, what was their radiation dose. But there are patient-specific risk factors as well. And the best treatment for this is complex decongestive therapy. So a referral to physical therapy, a physical therapist who has been trained in lymphedema therapy and can really take them through a course of treatment and get that fluid down, combination of massage techniques, compression, things like that. And so this is just a picture of actually what one of the compression garments looks like for head and neck. So even if you can't get a patient to wear this, you can still make improvement in their lymphedema. So radiation fibrosis. So we heard a little bit about fibrosis earlier today. And this is a picture from Dr. Stubblefield, who's a rehabilitation physician out at Memorial Sloan Kettering, who's really interested in this topic. So fibrosis is this progressive fibrotic sclerosis that is can be a delayed effect of radiation. Not all patients get it, but it can be determined by how big was the field, what kind of tissue did they have to start out with, what risk factors did they have diabetes, were they a smoker, things like that. And so the clinical symptoms of fibrosis depends what soft tissues were affected, but it can lead to weakness. You can get numbness, tingling, neurologic symptoms. It can be painful. It can lead to reduced range of motion. For this head and neck cancer patients, mostly neck and shoulder range of motion. It can lead to very painful muscle spasm, trismus, of course. And then the effect on function, which is what I care about mostly. So how does that affect their ability to reach overhead, their ability to bathe themselves, grooming, dressing, eating? And then finally, cancer-related fatigue, just a brief slide on that. So as you know, it's overwhelming sense of fatigue that isn't proportional to what they've been doing, but can really interfere with the usual functioning of the patient. Very common symptom, multifactorial etiology, so of course it has to be a multifactorial treatment. And so as I'm sure you all are aware, we're treating the underlying medical conditions, looking at their nutrition, their pain, mood, sleep. You can use neurostimulation, but something that I think is very exciting is that there is a lot of good research to show that exercise can really help in reducing cancer-related fatigue, both during treatment, after treatment. Really, anytime you can encourage your patients to get up and move a little bit more, you can actually reduce their fatigue. All right, so a little break here. So I love this picture. So at the end of the day, what's it all about? You know, I mean, obviously we're all here because we care about cancer patients and we want them to have an improved quality of life despite their cancer diagnosis. And you know, these are all things that we can treat as providers, and just to kind of think that our overall goal is to improve the patient's quality of life. So we had a thought at the Milwaukee VA, kind of looking at how are we identifying these functional needs? As we've seen, they're a little bit hard to tease out. Patients may or may not tell you about them unless you ask them directly. And you know, as clinical providers, we're all a little bit too busy and trying to do a little bit too much in clinic. So is there a way we could potentially screen for functional needs? And additionally, as you're all aware, that there is the Commission on Cancer standard to start screening for psychosocial distress, could we kind of piggyback a screen for functional needs on top of that? You know, another checklist, right? And looking at what are some of the more common tools used to screen for distress. I'll show you guys a slide of the NCCN distress thermometer on the next slide, but it really doesn't address functional needs all that well. It's pretty good for symptoms. It's pretty good for, you know, mental health and psychology referrals, but it's not very good for functional needs. And another kind of background to this idea was, you know, breast cancer, as I mentioned, has a very robust literature base supporting the need for early rehabilitation intervention. And just last year, a kind of multidisciplinary consensus group put together this supplement, this recommendation of breast cancer surveillance model, kind of saying that if we screen for not just psychosocial distress, but functional impairments, you know, at baseline, during treatment, after treatment, during survivorship, we can identify these functional needs early, intervene, and then hopefully reduce disability long term. So this is kind of the model. And again, here's the NCCN distress thermometer, and as you can see, it's a pretty good tool. I mean, it's easy to use. The patient can identify how much distress they're in by indicating on the thermometer. You know, it kind of breaks it down into some practical problems, family problems, emotional problems, so you can really kind of tease out some good issues for social work and psychology to work through. However, when you look at the list of physical problems over here on the right, you know, it kind of is a big mesh, mostly of symptoms, mostly of kind of things that, you know, could be side effects of treatment. If you look at if there's any functional problems in here, there's two, and they're not extremely specific. So do you have problems with bathing, dressing? Do you have problems with getting around? Now, you know, as a rehabilitation provider, that might be helpful, but we could probably do a little bit better. So what we decided to use, and I'm still not sure it's the best tool, but it was a move in the right direction. We were going to use the FACT-HN tool, and as many of you are probably familiar, it's a quality of life tool. It has been validated for many different studies, and it has, you know, 4 different areas that affect quality of life, and I'll kind of show you the different modules, and then a list of additional concerns specific for head and neck cancer. And so we initiated using this as a screening tool, kind of a cross-treatment for head and neck cancer, to see if we could identify these issues that were affecting quality of life for individual patients, and kind of monitor people's quality of life. And really, over time, our hope was to identify opportune time for referrals. You know, if the whole population was saying, well, at this point, my quality of life plummets, then, you know, maybe then all of our patients should be asked at that specific time, you know, would you like to be referred to social work, mental health, rehabilitation? Or additionally, looking at this tool within an individual patient, you know, well, you were here before you started your cancer treatment. Now you're here. Now you're here. Something's going on. What's going on? And kind of using it as an opportunity for a discussion with the clinical provider. So this is, I'm sure, a little bit grainy. I apologize. But you can see that the FACT is broken down into 4 sections. So physical well-being, social family well-being, emotional well-being, and then functional well-being. So there's a little bit of appeal to a rehabilitation provider that there are some subscales looking at function and physical well-being. The functional ones actually end up not being that helpful, but the physical well-being scale has a little bit more specificity in it. And then the additional concerns, again, a lot of these symptoms that we just heard a lot about, looking at specific to head and neck cancer. So what we did is we started using this tool about a year ago at our institution, and I have to thank all of the nurses in the radiation oncology and ENT clinics for actually giving these out and getting them in CPRS for us. So at this point, we've had about 140 patients complete just under 200 of these forms, and we've had a couple issues with, getting the form used and then making sure the patients are getting it across the treatment trajectory. So we've had a couple stumbling blocks along the way. But as you can see, at this point we have a pretty even distribution of about 30 patients before treatment, 30 patients after treatment, 30 patients at this kind of immediate follow-up phase, a little bit longer follow-up, and then some longer-term survivors, which has been interesting too. And just broad strokes, this is kind of average for the whole population. You can see that the variability within our population is huge. So it might not end up being a very good tool to kind of compare within the whole group, because you can see there are some people whose quality of life is fantastic and some people whose is not so good. But the trend overall, it does seem that kind of, from baseline to, right after treatment, it does dip a little bit and kind of hover around here. And then somewhere around a year, it does seem to kind of come back up to baseline. Although, again, these changes are not, it's more of trend than statistically significant. However, if you look at what the U.S. general population average score is, right about baseline and where we are in the end is kind of what our data shows. And then I think, interestingly, the minimally important difference is a good indicator of, maybe how we could use this tool in a clinic setting. And so the minimally important difference is that change in score that would lead a clinician or a patient to do something different because of the change in quality of life reported by the patient. And so for this one, you can see that it's about like 6 or 7 points, and there is kind of that drop for about 6 or 7 points for the whole population immediately after treatment. If you add in the additional questions specific to head and neck cancer, again, the trends are kind of all over the place, and you can just see the huge variability. So, and eventually what I'd like to do is really follow patients from baseline across the whole way and see what happens with the individual's report. I think that would be a more useful use of this tool. If you look at the physical well-being scale, however, the differences do seem to be a little bit more significant, and so there is a bigger drop from baseline to right after treatment, and then that kind of comes back up to baseline over time. And again, the U.S. general population is sitting right about here, so our population started a little bit higher and dropped a little bit lower immediately after treatment. And again, that minimally important difference, about 2 or 3 points, it might be the tipping point to talk to the patient. Well, what's going on? What are your issues? What can we help you with? So the summary of our project, it's not really a research project. It's more of a quality improvement project at this point. But the feelings of physical well-being and quality of life may decline during treatment, and this is kind of obvious, but during treatment for head and neck cancer, but do tend to improve over time. So during or immediately after treatment may be a critical time to really screen for quality of life, look at functional needs for your head and neck cancer patients, think about referral to rehabilitation along with mental health, social work, other things like that. And overall, really better tools are needed. So in the last couple minutes, I'm just going to talk a little bit about an upcoming project we have at our institution. I was hoping it would be a little bit farther along at this point, but we are still in the pre-study phases of this. So kind of thinking back, so we've kind of shown that head and neck cancer patients have many reasons to have reduced function, quality of life, fatigue, during treatment, specifically radiation treatment, as Dr. Murphy was highlighting a lot of the side effects of radiation treatment in this population. There have been a few studies looking at resistance exercise during and after radiation treatment to improve lean body mass and shoulder range of motion in this population. Aerobic exercise, however, we know is probably the best type of exercise to improve cancer-related fatigue. And so it may also be beneficial in this population, but it really has only been studied in one very small study that was published earlier this year, looking at an aerobic exercise intervention during treatment for head and neck cancer. And in addition, we wanted to look at some potential mechanisms for the benefit of exercise in this population. So we're looking at things like inflammatory cytokines, autonomic function, looking at heart rate variability, and then kind of tying it together with the HPA axis, so kind of looking at how endocrine function will vary as well. And so the aims of our project are really pretty narrow at this point, because we want to first see if this exercise intervention will be feasible. So we want to combine resistance and aerobic exercise for head and neck cancer patients during their course of radiation to kind of keep them more active, keep their physical function up in a time where their physical function would otherwise plummet. And we want to look at some novel mechanisms for this benefit. So again, looking at heart rate variability, cytokines, and the HPA axis. So we're planning to study or enroll 50 patients, head and neck cancer, all stages. So we are kind of looking across the continuum of types of patients who are going to be undergoing radiation. And we're going to randomize them to 2 groups. One will have a combined exercise during radiation, so 3 days a week, exercising with a research assistant right in the hospital. They're there for radiation anyway, so they're kind of a captive audience. Versus a control group who's just going to get some education about the benefits of exercise. These are our measures, and I'm most interested in things like physical function, of course, but we're going to look at aerobic capacity, quality of life measures, fatigue, depression, pain, shoulder, a whole bunch of things, probably too many things. That was the review I got on my first grant application. You are looking at too many things, so I'm trying to focus. And then this is what our study is going to look like. So we're going to enroll patients both at the VA and also at our affiliated academic medical center across town. And we're going to enroll them, randomize them into an exercise and a control group, do a 6-week intervention during that course of radiation, and then have 3-month follow-up to see if there was any benefit, as well as phone surveys later on. So that study will be hopefully going soon, depending on if I get my grant. So really the take-home points from my talk. So, one is when should I think about referring my head and neck cancer patient to rehabilitation? So really anytime there's symptoms like shoulder dysfunction, lymphedema, radiation fibrosis, fatigue, something that just isn't really getting better the way you would expect it to be getting better, think about rehabilitation. It really could help your patient. And anytime there's functional needs, so really very basic activities of daily living, walking around, going to the bathroom, bathing yourself, swallowing, communication, these really basic needs, everyone needs these things. And if your patients are having a hard time doing it, there's professionals that can help kind of assist them back to an independent level of functioning. Cancer rehabilitation is really a growing subspecialty in my field, and I think that as we understand a little bit more what the needs are of the population, we can really become an integral part of the cancer treatment team and kind of have it less be, we're over there and you're over there, but have it be more like a united team. So physiatrists, now you know what a physiatrist is. So we really do help coordinate team approach for function and quality of life. Focus on function is what I say all the time. That's what I do. I'm here to help you be more functional. What are your goals? What do you want to do that you can't do right now? Sometimes it's something as simple as I want to be able to, call my granddaughter on the phone, or I want to be able to get on the floor and play with my kids. Very simple things, but we can set up a plan so that the patient meets those goals specifically. And then future research plans, there's just a ton of opportunities to look at function and quality of life for our cancer survivors. And some acknowledgments. Mostly want to just say for my Milwaukee VA team, thank you for doing all the fact forms, because I know it hasn't been easy. And that's it.